Hello, everyone. I am here with the world-renowned Dr. Schultz, co-founder of the Centeno Schultz Clinic, pioneer in regenerative medicine. And for the upper cervical instability community, Dr. Schultz has been just hugely important in the development of a brand new procedure, which we refer to as the PICL. A few months ago, we did an interview with Dr. Schultz just doing a background of the procedure, how it's used, why it's important. But today we wanted to go through some questions that the community has been asking about the procedure and about the patients to see if we can get some insights. So thank you, Dr. Schultz, for joining us this morning.
Thank you, Alex, and it's always a pleasure. I appreciate the question and most importantly, the opportunity to elevate the conversation so people have the facts as opposed to the rumors that seem to be circulating.
Absolutely. So talk to us a little bit about the PICL procedure and how it is developed and changed over the past few years. I think I had my first PICL, gosh, it's got to be 3 or 4 years now. So talk to us about how the technique has evolved and also if the anesthetic has involved, because I think you're also an anesthesiologist, right?
I am. So we've been doing this now for the last 5 years. And any maiden voyage for anyone, whether it's the space program or on a sailboat, it's always a little nerve-wracking. So our first 100 cases were very challenging, shall we say. Now we're almost at 360 cases, and the world has changed. Our comfort level, our ability to get to the point where we need to has dramatically changed, but also the anatomy and our understanding. Now more and more imaging has become available in terms of actually seeing all the different bands of the alar and the transverse ligament. And that's been absolutely critical. So we have a better understanding of the anatomy and the approach is slightly different. So as you mentioned, you had the more than one PICL. And now what we're doing for those patients that come back, we inject above the atlas. So we inject below initially on the people's first injection, but more often than not always, but more often than not, on the second and third go around, we're actually getting the upper fibers when we go above the atlas. Now, this is really an uncharted territory for most people, but we feel very comfortable and we're seeing some significant results by doing that. In addition, the anesthetic has dramatically changed. As you know, we have a patented oral appliance, which is undergoing another revision as we speak. In addition, the anesthetic technique has changed. I have instituted a lot more local anesthetic in the back of the oral pharynx, which has decreased the amount of anesthetic that's required. So more and more patients are pretty wide awake within 1 hour in the recovery room. What that means is they don't feel so dopey and they don't have the side effects, particularly nausea.
That's great, but you're still injecting Dr. Schultz loving kindness, right?
Absolutely. I mean, first and foremost, this is a frightening procedure. This is more often than not, people have bounced from physician to provider to physician. Regrettably, many patients have been talked down to. They've been dismissed. They've been disrespected. And that's because, regrettably, this collection of patients, their symptoms don't fit into the traditional box of medicine. And so, yes, first and foremost, we are compassionate and we listen. We listen to your symptoms and we honor them because they're real.
Yeah, I remember I had at least 3 practitioners, one of them a PhD in neurological physiotherapy. So PhD in physical therapy, PhD in neurology, telling me there's no way that you can have vertigo unless it's an inner ear problem. This is at Anschutz in Colorado. Can you believe that? So yeah. I want to dive into something you said. You said 360 cases. So when you say 360 cases, is that 360 different people or is that 360 events? Because I want to dive into how many PICL should someone plan on getting?
Great question. So I would say in terms of procedures, we're at about 360 right now, and we're averaging between 3 and 4 cases per week now. So we feel much more proficient. Our scheduling is better, and people are actually getting the message, whether it be via platforms like this, Dr. Centeno's Facebook, or multiple blogs. So patients are getting the treatment that they need now.
Now, I know when I first had my procedure, I was a huge experiment because we didn't know what would, if it was going to work, what was going to happen. And because I was part of the clinical study, I basically signed up for 2. Now, my first procedure, afterwards, within 6 months, I didn't have any symptomatic relief, but I could feel that my neck was more stable. Now, if I had to pay for the second procedure, I might not have, because I might have looked at that and said, I don't think I got anything out of it. But after the second procedure, I had a huge symptomatic relief several months later. How are you guys talking about with patients the fact that they might not see a lot of benefits after the first, and what are you communicating in terms of what's standard for how many they should get, or maybe we don't know the standard yet?
Great question, Alex. So 2 different paradigms here, right? So you were part of the study, right? The study, the patient is blinded. They don't know. There's no communication. And that's still the way we handle patients in our study. There's no communication. There's no expectation. There's no acknowledgement of what they got. 0. And that's the way it will be. And the study has actually been extended. I think it's either to 3 or 4 injections now. So it's much more involved.
Sign me up.
Okay. Now, in terms of a clinical patient that's not participating in the study, we have a very candid discussion. This is an experimental procedure. It may or may not help you. Your candidacy is based upon A, B, C, D. Then we give you a candidacy rate. We tell you the risks, which are including but not limited to, as you know, bleeding, infection, failure, escalation of pain, nerve damage, spinal cord injury, and possible death. Other than the transient increase in pain, we've had no complications. But we can tell you almost categorically, most patients need more than 1 procedure. That's almost across the board, if that helps.
Yeah, so let's talk about the study, because it sounds like the method, or at least how many times you're doing the injections, has changed. So is the study different now? Is it a new study? Has the old study been wrapped up? What's going on?
Yeah, so like everything on its maiden voyage, it wasn't perfect. So we've tightened up the protocol and the inclusion, and most importantly, the exclusion. Patients with hypermobility are not allowed to participate, because that really is an outlier and it can absolutely impact the data. So we have really honed in the criteria, and patients have to have, they have to have functional compromise. They have to have the cardinal symptoms. They have to have imaging to support it. And they also have to have exhausted conservative care. And they cannot have hypermobility.
So let's talk about hypermobility for a second. So when we say hypermobility, are we really talking about EDS?
So when we talk about hypermobility, we're talking about a spectrum, right? Not everyone has the means or the community to support the formal diagnosis of EDS, right? And what if you live in somewhere rural in Mexico? You're not going to have that diagnosis, or even rural Montana. You're not going to have it. But it's pretty easy on physical examination to determine whether or not there is some ligamental laxity. Do we need a formal diagnosis by a neurologist? No.
So one of the questions that we see a lot online is, does this mean that EDS patients are not going to benefit from it? Should they be investigating getting this procedure done at all?
Great question. But just like anything, there are different spectrums and there are different severities of EDS, right? So will the patients benefit? More likely than not, yes. Will they benefit as much as someone that doesn't have EDS? Probably not. But also in that conversation, if they have significant EDS, the likelihood of them having a significant, sustainable outcome from a fusion goes dramatically down because of the instability. So you have to look at, well, what are my other options? And for severe EDS, surgery is not a very tenable option.
Yeah, it doesn't seem like a fun option for anyone. So
No.
so let's talk about the results, right? Because it seems confusing for a lot of us who've had the procedure. There seems to be three buckets, okay? There's the group that I'm in, that I'm very lucky to be in, where I can say this totally transformed my life. I don't know where I'd be today if it wasn't for this procedure. I feel like I have my life back, right? And I know that there's others like me out there. There's another bucket that have had the procedure done a few times, and they say, I feel a little bit better. I'm glad I did it. It wasn't a hole-in-one. Not feeling great, but it did help some. And then there seems to be a large bucket that we see of people who say, I got it done. It made me worse, at least initially. That's, we always say you got to hold on, but it
Yeah.
didn't help. It didn't help at all. And so, for those of us who have had this life-changing experience like myself, the message that I tell people is, look, don't make any judgment calls until you're at least 4 or 5 months out. You're likely going to feel awful, worse than you did before for 3 months. And unless you've had the procedure done at least 2 times, don't throw in the towel yet, because I didn't have any symptomatic relief until after my second procedure. But what are you guys seeing in terms of the study? Is there anything to share? Because I know that patients just really want to know, as do you, will this help, and or do we have any leading indications that this is going to help?
Yeah, it really comes down to the workup and the evaluation. Um, are there other factors, or are there other pathologies, which oftentimes are the case? Do they have some other coexisting problems? Do they have lower disc injury? Do they have lower facet problems? Do they have a spinal leak? Are there other extenuating or multifaceted issues that come into the diagnosis? So that is where Dr. Centeno and I are pretty meticulous in dissecting out. Is this a clean cranial cervical instability issue? Or is this someone that's already had multiple surgeries on their neck, possible disc replacements in their neck, possible dural leak or spinal headache, and disc injury? So our job is to identify those patients that more likely than not have pure cranial cervical instability and address that. Unfortunately, we don't live in a perfect world, right? Oftentimes patients have had other problems and those have to be addressed. And that doesn't even address the patients that have had all sorts of surgical decompressions of the nerves in the back. And then they have compression or scar tissue or adhesions, which even clouds the picture worse. So what I'm trying to say is Dr. Centeno and I are very meticulous and attempt to identify those patients with pure cranial cervical instability, like you, that had a traumatic injury, that don't have other coexisting. And with those patients, more likely than not, they will require more than one. And more likely than not, that patients, those subset of patients, more likely than not will have a profound or a very good, shall we say, outcome.
And so as there are additional factors going into this, that seems to reduce the effectiveness, would you say?
Well, it complicates the clinical picture, right? I mean, it may reduce it, but it also requires that we pay attention to those other issues, right? If they've had the the occipital dissection and their scar tissue, or they've had disc replacements, or they've had fusion, and now they have adjacent segment. It just complicates it. So we may get the cranial cervical instability improved by DMX and or MRI, but there are other generators, there are other potential sources of pain that are regrettably plaguing the patient. Does that make sense?
Yeah, it makes perfect sense. So let's talk about one of the things that we see a lot online in particular when we're talking about complicating the clinical picture, and that's tethered cord.
Yeah.
Why does everyone in the last 6 to 12 months think that they have tethered cord? I had never heard of it, and it seems to be a brush fire everywhere in the upper cervical community. Is everyone just finding out that they have it? From your perspective, what's going on here?
I think that the Facebook group is tremendous. I think it serves in a very important role. At the same time, it can also work against us or populate a very idea like tethered cord, such that it becomes like rapid wildfire. It becomes out of control. Someone mentions it, and then the doubt seeps in, so everyone thinks that they have it. And I think that's what's happened here. That also happened with Eagle syndrome, right? Hyoid compromise. It's a very, very rare condition that is associated with swallowing dysfunction. But again, someone picked it up and took it. And regrettably, some patients in this group have had surgery and have not fared well.
So this isn't the first time that we've seen a craze in this community. So Eagle syndrome happened a few years ago, it sounds like.
Yep. And so we just have to tamp down the enthusiasm and the query. Again, surgery forever changes the biomechanics of the body. It's not like getting your tires changed or your oil changed. Once you have surgery on either your neck or your back, it's forever changed. It's much better to treat it with injections. And if they don't work, you can then have surgery. But it's not the other way around. Once someone starts cutting into your low back, those are forever changed.
Absolutely. So going back to the study, right? We know that it's hard to really tease out data quite yet because we're sort of revamping the study and making sure that we have better exclusion criteria. But are there any tidbits of results, even if they're qualitative or anecdotal, that you can share maybe about patients?
Well, the things that we know is those patients with cranial cervical instability, pure cranial cervical instability, more likely than not, will need more than one injection. Number two, what we know is that there are basically two groups of patients. Those patients, like the rugby player or the football player, or the patient that's sitting at the red light that gets clocked. Traumatic injury, no prior history, now we're changed. There's a temporal relationship, car accident, onset. Those patients are different than those patients that have ligamental instability due to hypermobility. And call it what you will, it's somewhere on the spectrum. Is it formal EDS? Is it hypermobile EDS? Or is it just some hypermobility? Those patients are different. That's all we can say. We have not been able to quantify it, but they are different.
So I'm just curious, what have you seen, whether it's the causes of upper cervical instability or the treatment or the outcomes, what have you seen that has personally surprised you throughout all of this?
The things that have surprised both Dr. Centeno and I are those patients that with good intention, and I do mean good intention, that have sustained some sort of minor setback, they go to a chiropractor and they have a high velocity adjustment, and forever their lives are changed. It just takes our breath away. They were doing what they were taught to do, and there's no going back. I mean, they are forever changed. So that's just a word of caution to everyone out there. We believe in chiropractors. We endorse chiropractors, but those patients that have had those high velocity changes will testify that their lives are forever changed. That's what's really surprised us.
Yeah, absolutely. And I've been seeing that more and more. And when I was initially after my adjustment, you have no idea how many chiropractors and physiotherapists told me there is no way that a chiropractor damaged those ligaments because they're too strong. And I said, really? Because I went in, I was normal. I walked out, I wasn't.
Yeah, yeah. So
Yeah.
that's the one thing that really has surprised us. I mean, the high velocity rugby player that's playing for Ireland or the football player, that's pretty, that's to be expected. There's quite a bit of G-force, but just going into a doctor's office and having a high velocity, it's really surprised us.
And for those listeners out there, if you're in the Colorado area, Dr. Katz, who I know works very closely with the Centeno Schultz Clinic, he's up in Boulder, very highly regarded chiropractor in this area. And then we've got Dr. Rosa up in New York City, who's
Yeah.
very familiar with craniocervical instability, also has worked with you guys. And if you're not in New York or Colorado, which most aren't, finding an AO at I can't say it, Atlanta. Oh gosh, what's
Atlanto-occipital and AO.
Atlanto Occipital? Yeah, AO chiropractor or a NUCCA, NUCCA chiropractor. These
Yeah.
are great. Would not recommend upper cervical chiropractors that use the Blair technique. It's a little high velocity, my personal experience. But yeah, thanks for sharing that. It's comforting, but not great to hear that there are a lot of other patients like me who were damaged by chiropractors. So, next question here, are you seeing any symptoms in patients that are more responsive to this, that are improving more, and any symptoms that are less responsive to the procedure, like headaches or vertigo, neurological things?
Symptoms. So soon we'll be publishing a Word doc or a cloud document that basically prioritized. We've been collecting all the data on every patient, and what came out was headache. Headache seems to be at the top of the symptoms, along with brain fog, and those were to be expected. I mean, I think everyone in this community knows that. But what was not expected and what was interesting, that was lower in terms of prevalence, but still important, was thoracic pain. Thoracic pain and shoulder pain. So Dr. Centeno and I are going to be spending much more time kind of evaluating. And for my patients, I've started treating the ligaments all the way down to the mid-thoracic, not just stopping at C7T1, but going down, acknowledging that more likely than not, the ligaments are impacted.
Well, what I found over my 4 procedures was that the lower spine is actually compensating whenever the upper cervical is out of alignment. And so every single injection a few months later, my spine, where it would try to compensate, it would go down. So I used to have a lot of tightness and pain in my upper thoracic. That went down the mid back, then it went down the lower back, and then it's down in hip. And the only time I have hip pain now is if my upper cervical is out of alignment. So are you seeing these sort of strange compensating issues with patients?
Absolutely. And it also, there's a key driver of this is posture. For those patients that, I mean, in a perfect world, Alex, the ear should be in alignment with the shoulder. But all too often, because of COVID and all the computer work that we're all doing, we start doing this. And as we do that, then our thoracic spine starts slumping. We impinge at 0, 1, 1, 2, and at 5, 6. And it has a cascading effect. So I'm meticulous in terms of getting up every 20, 30 minutes and moving around, as opposed to slumping towards the end part of the day. And I would advocate that for everyone else.
And are there any resources you would recommend for postural improvement, maybe recommended reading? I've heard of Agoscu, for example.
Yeah, Agoscu is very effective for those patients that are local, and also, the local, there's a local provider, Todd Ball, who works on neutral spine alignment. He also has a virtual program accessible by the internet. It's called SymFit, SYMFIT. He's been effective in working with patients outside of the Denver area virtually in terms of getting alignment. And he has a good sense of the CCI community and those patients with hypermobility.
Very good. So I'm going to shift gears here to go into some specific questions from the community.
All
I mean,
right,
these have all been questions from the community, but these are a little bit more specific cases.
let's roll.
So we're going to hop right in here. First question, is there a grouping of overhang numbers that correlate with percent of healing after the PICL and the number of treatments needed? For example, people with less than 4 millimeters have a 90% success rate and need to have PICL treatments, whereas 4 millimeter to 6 millimeter have a 70% and usually need 3. And also, how does having only one side having an overhang on the DMX impact all of this? Or do we know quite yet?
We don't know. Those are all really good questions. And for your listeners, are you going to tease that out just so for those patients that are not fully versed what that might mean?
Let's tell them.
All right. So the overhang is the C1 over C2. It's an overhang. It's basically a result or one of the test results from DMX. Over 3 is abnormal, along with periodontoid asymmetry. Over 4, it's 99% sensitive. The question is there a correlation with the severity of the overhang and clinical improvement and need for treatment? To date, there is not. It's a great engineering question that we're working on now. It doesn't address, though, the issue is this a traumatic injury or is this a patient with ligamental instability? So I think those will have to be teased out separately, but a great engineering question.
Right. So next community question is, to what extent does lower cervical instability affect the PICL outcome? Are posterior injections as effective for lower instability as the PICL is for upper?
Again, we haven't teased this number out, but clinically, Dr. Centeno and I are very keen in focusing both not only on the upper, but also the lower, because the cervical spine works in tandem. I mean, you can't ignore one at the expense of the other. So it's critical. The posterior approach is critical for those lower cervical discs, facets, ligaments, and we treat them accordingly.
And are you guys still doing the posterior injections with the PICL sort of as a combo? Is that typical?
Yeah. So two points here. We almost universally inject the alar, the transverse, the anterior longitudinal ligament, and then inject the 0 to 3. In fact, the new study requires that, whereas the studies that you were in initially, that wasn't part of it. That's how important the upper cervical facets are.
So next question here, we talked a little bit about EDS, and this question gets into that a little bit. Can you please tell us a little bit about the prognosis and complications for patients with EDS? Specifically, how many EDS people have you treated and what are the outcomes? This patient says, right now, I cannot get any information on how many they treat and what the prognosis looks like. It's all anecdotal and reference driven, which is not data driven enough for me. And I think we would all want more data, right?
Yeah, I mean, great question. And my heart goes out to the person that's asking this question. If they have EDS, I understand your frustration. I do. And you have to understand that this is not a university-backed or governmental-backed program. This is Dr. Centeno and I and the Centeno Schultz Clinic. We fund all this. There is no government funding this, particularly during COVID. So we're doing the best to answer these really important clinical questions. So we're not ignoring it. And I think you also, at the same time, have to honor and acknowledge that there are different types of EDS with varying severity. So this is a multifaceted complicated question. So we're working on it. We're crunching the numbers, but we don't want to be premature in terms of putting out the data at the expense of it being incorrect.
Which I really respect in you, Dr. Schultz, and also with Regenexx, is you're not willing to rush the process, the scientific process, to get numbers out there. You want to make sure that you're doing the right things in the right order. And I think we'd all love to have more clarity on these topics, but you know, you guys are really well known and you're great and you're bigger than most clinics, but in the grand scheme of things, it's a small shop in Colorado, and you guys are pumping out incredible research, but you're not government backed. You don't have millions of dollars of funding. It's just a totally different ballgame.
Well, in addition, I mean, we work 7 days a week. I mean, we run a very busy clinic Monday through Friday, and then we work most nights and every weekend. So we are dedicated to this group of patients, number one. We honor the condition. We are committed to making a clinical improvement for those patients and their families. That's the calling we have. We also only have so much time and resources, but we will get to this. Just be faithful.
So speaking of your contributions to this community, what's going on with I think it's called the Upper Cervical Institute, right? You and
The
Dr.
CCI?
Centeno? Yeah, the CCI. What's going on with that?
So we have increased our availability at the expense of kind of reducing, if you will, our willingness to treat some of the knees and the shoulders and the ankles that really for the last 15 years, that's where our focus has been, and that's what we have been doing. But now Dr. Centeno and I have opted to create a new chapter for ourselves and the community at large. Our schedules are going to be increasingly focused on the cranial cervical group and reducing the amount of lower extremity stuff, because we feel that this is the time. We have enough experience. We have enough now people in the studies, and we're starting to crunch some of the numbers. And we want this community to get better. We want these people that have been bedbound, that have been housebound. We've seen people from all over the world whose lives, whose futures have been irreparably changed as a result of this condition, and we want to respond.
You guys are doing good work. So what's new with COVID? You guys are still operational, right? What challenges have you been facing?
So I think we were one of the first practices here in Colorado to be really honor this and to implement a series of changes. And so it starts at, we have no waiting room. There is no waiting room is in your car, independent of how cold it is. Number two, everyone gets a temperature the minute they come in the clinic. That includes all staff members. All staff members get it twice a day. All staff members have had both vaccination injections or both injections. Everything gets wiped down between cases. Everyone has a mask, preferably an N95. And then we get antibody testing once a week from all the staff. In addition, our HVAC has filters for the COVID. And we have had no outbreaks in the clinic over the last year now.
That's fantastic. Wow, once a week for antibody testing. That's hardcore, Dr. Schultz.
Yeah, everyone's arm or finger, you can either stick it or go through here. So that's our commitment. We are leaders in this, and we want our patients and their families to trust us. And so unless you maintain that high level, you're not doing a service.
And that's just one of the things that I really admire about you and your clinic is your commitment to clinical excellence and you're not willing to cut corners. You're going to do it the right way.
We have to. Again, the patients at large need us. The patients at large and their families are struggling, and no one seems to be responding in a compassionate, authentic way. And surgery is not the only way. And in 2021, Alex, our goal is not only to reach out to these patients, but we're also going to now talking, and we're actually, I have a talk later today, speaking with the physical therapists that see these patients and letting them know that there are non-surgical options. Also talking to the GPs that treat patients with EDS. And then I'm not sure how receptive, but we're also going to approach the surgeons and say, guys, there is a different option. And if we just want to let you know that we're here for you.
So 2 wrap-up questions, unrelated, but my 2 final questions are, how can patients like me who've had the procedure and had good results, how can they best support you all and your clinic and your efforts? That's my first question.
Well, first off, thank you for a forum like this. And I think the second way for those patients that have had a profound change, and I've had some of my patients do this, is give us a testimonial. Give us a testimonial, and that I can put, or Dr. Centeno can put on a blog, because that goes on and on and on. And oftentimes it can become actually a source of encouragement and hope for those families that are not in big communities, that feel boxed in and hopeless. If we can give someone 1 ounce of hope, you've made a difference.
Absolutely. Last question. What's one question I should have asked you, but I didn't? And the answer, please.
What happens with if a patient has a high total nucleated stem cell count, or all the cells utilized? And the answer is yes. I make a list of where I want to inject the patient, and I'm with the patient. And then I always have a caveat, right? The caveat is if you have enough cells. And if you don't have enough cells, I always have a backup plan, and I use platelets, right? So if we don't have enough cells, I want to do the lower cervical facets and ligaments, I always have plan B. But if they have sufficient cells, we always use them. They're not thrown away on my cases. So I just want to put everyone at ease. When you have enough cells, they will all be used.
And you can use them for like wrinkles under the eyes, right? No, not using it for that.
Okay. Alex, thank you so much. I hope this was helpful. Thank you for carving some time out for this. I hope it was helpful in dissecting some of the very important questions.
Absolutely. Thank you so much, Dr. Schultz. Hope to speak with you again in the future. Thank you for all your work.
Thank you, everyone. Bye.